Good morning, sir and ma'am. Myself, Momita Devarma. Today, I am going to discuss about hypoglycemic drugs. First, what is hypoglycemic drugs? Hypoglycemic drugs are synthetic drugs that lower the blood glucose levels and are used to treat type 2 diabetes mellitus. They may stimulate the synthesis of insulin by pancreatic beta cells and inhibit glucose production. It is facilitate transport of glucose to muscle cells and sometimes increase the number of receptor sites where insulin can be bound and can initiate the process of breakdown of glucose. Diabetes mellitus is also considered as one of the most common hormonal disorders in dogs and cats. Then come classification. First, insulin secretagogues under the sulfonylureas and meglitinin analog. Second, insulin sensitizer under this biguanide and thiazolidinediones. Number 3, alpha glucosidase inhibitors, and number 4 is dipeptidyl peptide 4 inhibitors. Then come insulin secretagogues. First, sulfonylureas. There are two generations. In first generation, drugs are talbutamide, chlorbromamide, acetohexamide, tolazamide, and the second generation drugs are glibenclamide, glipizide, gliclazide, glimepiride. These drugs are classified as insulin secretagogues because they promote insulin release from beta cells of the pancreas. Primary drugs used are talbutamide, and the second generation derivatives are glyburide, glipizide, and glimepiride. Glipizide is contraindicated in dogs. Then come mechanism of action. Stimulation of insulin release from the beta cells of the pancreas by blocking the ATP dependent potassium plus channels, resulting in depolarization and calcium plus influx, reduction in hepatic glucose production, and increase in peripheral insulin sensitivity. Talbutamide, that is first generation's half-life is 6 to 12 hours. Pharmacokinetics is orally administered, some converted in liver to quickly active hydroxytalbutamide, and some carboxylated to inactive compound excreted through renal. Then adverse effect of drug is hypoglycemia, may decrease iodine uptake by thyroid, contraindicated in liver failure and renal failure patients. Glibenclamide, that is second generation, half-life is 18 to 24 hours. Pharmacokinetics is orally given. Some is oxidized in the liver to moderately active products and is excreted in urine. That is 50% is excreted unchanged in the feces. Adverse effect may cause hypoglycemia. The active metabolite accumulates in renal failure. Then meglitinin analogs. This class of agents include ripaglinide and nataglinide. Although they are not sulfonylureas, they have common actions. Mechanism of actions, and their action is dependent on functioning pancreatic beta cells. They bind to a distinct site on the sulfonylureas receptor of ATP sensitive potassium channels, thereby initiating a series of reactions culminating in the release of insulin. In contrast to the sulfonylureas, the meglitinides have a rapid onset and a short duration of action. They are categorized as postprandial glucose regulator. Meglitinides should not be used in combination with sulfonylureas due to overlapping mechanism of action. Then pharmacokinetics. These drugs are well absorbed orally after being taken 1 to 30 minutes before meal. Both meglitinides are metabolized to inactive products by CYP3A4 in the liver, excreted through the bile. Adverse effects are incidence of hypoglycemia is lower than that of the sulfonylureas. Repaglinide has been reported to cause severe hypoglycemia in patients who are also taking the lipid-lowering drug gimfiprozil. Weight gain is less of a problem with the meglitinides than with the sulfonylureas. Must be used with caution in patients with hepatic impairments. Second is insulin sensitizers. In this, first thiazolidinedione. Currently marketed thiazolidinediones are rosiglitazone and pioglitazone. Mechanism action is bind to a nuclear receptor called the peroxisome proliferator activated receptor gamma, which is complexes with retinoid X receptor. Peroxisome proliferator activated receptor gamma and retinoid X receptor complex bind to DNA, promoting transcription of several genes with products that are important in insulin signaling. Pharmacokinetics. Orally absorbed, highly plasma protein bound, peak plasma contraction within 2 hours. Liver enzymes. Rosiglitazone metabolized in urine, pioglitazone metabolized in bile. Then unwanted effects: weight gain, fluid retention, headache, fatigue, and gastrointestinal disturbances have also been reported. Thiazolidinediones are contraindicated in pregnant or breastfeeding women and in children. Biguanides. Metformin is only drugs of this class presently available in market. It does not cause hypoglycemia. Then mechanism of action is they increase glucose uptake and utilization in skeletal muscles, thereby reducing insulin resistance and reduce hepatic glucose productions, that is gluconeogenesis. Pharmacokinetic aspect. Metformin has a half-life of about 3 hours and is excreted unchanged in the urine. Unwanted effects are those related gastrointestinal disturbances. Lactic acidosis is a rare but potentially fatal toxic effect. Long-term use may interfere with absorption of vitamin B12. Contraindications. Metformin should not given to patients with renal failure, hypoxic pulmonary disease, heart failure, and hepatic disease. Then number 3, alpha glucosidase inhibitors. Acarbose and inhibitors of intestinal alpha glucosidase used in type 2 diabetes. Mechanism action is it delays carbohydrate absorption, and reducing the postprandial increase in blood glucose. Unwanted effects are flatulence, low stools or diarrhea, and abdominal pain and bloating. Like metformin, it may be particularly helpful in obese type 2 patients, and it can be so co-administered with metformin. Number 4, dipeptidase 4 inhibitors. Uh, Dipeptidase 4 inhibitors or gliptins are a class of oral hypoglycemic that blocks dipeptidase 4 inhibitors. They can be used to treat diabetes mellitus type 2. The first agent of the class, sitagliptin, was approved by the FDA in 2006. Sitagliptin is an orally active dipeptidase 4 inhibitor. Then come mechanism of action. Sitagliptin inhibits the enzyme dipeptidase 4 inhibitor, which is responsible for the inactivation of certain hormones such as glucagon like peptide 1. Prolonging the activity of certain hormones results in increased insulin release in response to meals and a reduction in inappropriate secretion of glucagon. Then come pharmacokinetics. Sitagliptin is well absorbed after oral administration. Food does not affect the extent of absorption. Majority of sitagliptin is excreted unchanged in the urine. Dosage adjustments are recommended for patients with renal dysfunction. Adverse effects are nasopharyngitis and headache. Thank you.